various methods of induction. We have mechanical methods and drugs. So one is the membrane sweeping, that is sweep stretch we do. We can also give drugs like the dinoprostone gel, which can be given, or it is also available in the form of vaginal insert. It is only given when the cervix is unfavorable, that is the Shop score less than 6. Misoprostol, that is PGE1, can also be given for a cervical rightening, and it is usually given in term pregnancies at the dose of 25 microgram per vaginally every 4 to 6 hours. Remember that misoprostol is contraindicated in a previously scarred uterus. Foley's catheter, that is a balloon catheter, or mechanical dilatation of cervix can also be done. This is an excellent tool for inducing in cases where misoprostol or the drugs are that is prostaglandins are contraindicated. Hence, it's a very good tool in case of previous cesarean sections. Oxytocin infusion is given only after the cervix has ripened, and this is a very important point to remember. Often induction with oxytocin is started before the cervical ripening has happened, and this leads to failure of induction. So remember, always after this ripening of cervix you should start oxytocin, and it should be done in a controlled IV infusion by checking and titrating the drop rate. The one more method which is popularly done is the amniotomy, or the ARN, that is artificial rupture of membrane, and this is only done when the head is engaged and the cervical dilatation is more than equal to 3 centimeter. So these are the very important points where you have to remember when to induce and what are the methods to induce. Also remember that in cases where vaginal delivery is contraindicated, you are not going to induce at all. These include your other obstetric complications like your placenta previa, vasa previa, any suspicion of CPD, or previous classical cesarean section. In all these cases where per se vaginal delivery is contraindicated, you are not going to induce her. So also remember that when she crosses 40 weeks, there are certain methods in which you can allow her to continue the pregnancy up to 41 weeks by monitoring certain aspects. The most important tool in that we have is a daily fetal monitoring count. She can go back home and she has to do her DFMC. Charting has to be done. A total count of 10 in the DFMC is considered normal. I have already made a video on what are the methods of calculating the fetal moment, so you can check that video as well. Also, NST can be done twice weekly. Then amniotic volume, that is AFI, should be done weekly or bi-weekly depending on her gestational age. Then modified BPP has to be done twice a week, and even Doppler should be done whenever you are suspecting any IUGR. So these are the important points to remember in a nutshell about the post-dated versus post-term pregnancies. I think postgraduates often get confused in these two terminologies, and they end up messing it up in writing the diagnosis on their case sheets. So this is the way you are going to write it and also assess the pregnancy. So with